Welcome to the Stanford Precision Health for Ethnic and Racial Equity, or SPHERE, and our Transdisciplinary Collaborative Center's Precision Health Equity in Primary Care seminar series. Today is actually the third seminar in our four-part series, and our focus today is on pharmacogenomics in underserved communities. Next slide, please. Great. So my name is Lisa Goldman Rosas. I'm an assistant professor in the Department of Epidemiology and Population Health, and also in the Department of Medicine in our Division of Primary Care and Population Health. I also am lucky to direct our Stanford School of Medicine Office of Community Engagement, and also involved in our Stanford Cancer Institute Community Outreach and Engagement. And I'll be your moderator today. And I'm here joined by my wonderful co-host, Dr. Sean David. Dr. David is a program director of the Translational Science Outcomes Research Network, as well as vice chair for research in the Department of Family Medicine at NorthShore University HealthSystem, and clinical professor of family medicine at University of Chicago School of Medicine. So we have two goals today during our time together. So first is to describe examples of pharmacogenetic tests and relevant drugs and how genetically tailored medication treatment can improve patient outcomes. And given our focus on health equity, our second one is also to understand the challenges and limitations of applying evidence from European ancestry populations to diverse populations and evidence-based approaches to apply pharmacogenetics to patients from all backgrounds. So as a reminder, this series is accredited for 1 hour of CME credit. Today, we're gearing it towards primary care providers, and especially those who work with diverse communities, as well as those who work in community health or federally qualified health centers. All right, next slide. Okay, I'll go over our agenda. I will introduce each of the speakers individually and then pass it off to our three speakers. Our first speaker has a recorded video since she wasn't able to be here live with us today. And then at the conclusion of all the speakers, we'll host a Q&A. So that is an indication to you to please go ahead and submit your questions in the Q&A box down below. During the session. We'll be monitoring the Q&A box, and we'll be sure to get to your questions at the end. Okay, so before we move on, I'm going to ask Sean if he can please go ahead and share after I introduce our first speaker. Dr. Latha Palaniappan is an internist and a clinical researcher here at Stanford. Her research is focused on the study of diverse populations, chronic disease, and prevention. Dr. Palaniappan specifically seeks to address the gap in knowledge of health in Asian subgroups and other understudied racial ethnic minorities. During her time previously, prior to Stanford, at Palo Alto Medical Foundation, as the medical director of clinical research, she led the organization-wide initiative to collect patient race and ethnicity and language information, which enabled researchers, such as myself, to conduct disparities research using electronic health records in that system. She is the co-founder of Prana, a South Asian wellness program. Her current work examines the clinical effectiveness of structured physical activity programs for diabetes management, as well as physical activity programs for normal weight patients with diabetes. She was recently awarded a Mid-Career Investigator Award by the National Institutes of Health to provide mentoring to junior clinical investigators in the conduct of patient-oriented research. She is currently working on implementation of evidence-based genetic and pharmacogenetic testing in primary care clinics as the scientific director of precision genomics and pharmacogenomics in primary care, along with Dr. Megan Mahoney, another one of our panelists today. So with that, I'd like to pass it off to you, Sean, so you can share Dr. Palaniappan's video.
So what is pharmacogenomics? So all of us as physicians and patients know that not all people respond to the benefits and side effects of medications the same way. And pharmacogenomics are inherited the same way as our hair color or eye color, but it's not something that we sit around at the Thanksgiving table and talk about. How did you respond to Vicodin or clopidogrel or warfarin, any number of the medicines that I'll talk about today. So pharmacogenomics is the study of how your genes can influence your response to medications. Your genetic variations can determine how medication is absorbed, metabolized, and processed by your body, and how this may interact with other medications or supplements. So we refer to this as drug-drug and drug-drug gene interactions, in addition to drug-gene interactions. So at Stanford, we are fortunate to have really the father of this field, Russ Altman, and Dr. Russ Altman taught me pharmacogenomics about 5 years ago when we started the clinic in pharmacogenomics in our concierge and executive health program. And so this is a database that culls all of the scientific literature and provides information on 647 drugs and 133 pathways, provides dosing guidelines, and this takes information from all areas of the world, including the Dutch Pharmacogenomics Working Group, and compiles data also on drug labels from around the world. Next slide. And then we have specifically, and this is part of the consortium that I'm working on for the statin guidelines, the Clinical Pharmacogenetics Implementation Consortium. So this tells us as physicians, when we see these pharmacogenetic variants, when do we have strong evidence to change dosing or prescribing, and when is the evidence a little bit weaker, and helps us identify areas that we need more evidence. Next slide. So this is an example of a report that we get at Stanford in our pharmacogenetics consultations. Next slide. So you can see some of the enzymes that we talked about already today, CYP2D6, CYP2C19, BCORT-C1, SLC01B1, CYP1A2. And these enzymes can tell us about 400 different drugs. So we look at these 25 different areas of the genome, these variants, and it can tell us about 400 drugs, including commonly used cardiac drugs, antidepressants, anticoagulants, statins, antivirals, opioids, and also over-the-counter analgesics. Next slide. So this goes back to our study in human-wide, where we did pharmacogenetics consultation on 50 patients. So on the y-axis, you see the number of recommendations that we made, and on the x-axis, the different classes of drugs in which they were made. So psychiatric drugs, statins, isoniazid, opioids, clopidogrel, antihypertensive medications. And we made either preemptive recommendations, so that is a recommendation made before the person was actually on the drug, but they had a high likelihood of being on the drug given their medical and family history. So for instance, if people had a family history of cardiovascular disease, we made a preemptive recommendation on statins because most people who have a family history of cardiovascular disease at some point in their life do go on these cholesterol lowering drugs. And then reactive recommendations are those in which people are already on the drugs, and then we're making recommendations to lower the dose or change the drug. Next slide. And then looking at our phenotypic results based on select genes. So on the left-hand side, you see the pilot study, the human-wide pilot study. And the right-hand side, the general population level estimates for these different enzymes, CYP2D6, CYP2C19, CYP2C9, and SLC01B1. And you can see, in general, our pilot population was less likely to have normal metabolism. And this may be due to the fact that our population is more diverse. So you can see that the referent group, the larger populations that have been studied, and we'll take a look at how diverse groups are underrepresented in what we deem to be the population prevalence estimates. are mostly Caucasian, and in our pilot study, as you know, by the Bay Area, only 50% Caucasian, so more diversity represented. And there may be more variants that are concerning in terms of drug metabolism in diverse populations. Next slide. And we did analyze our Stanford primary care patients. So we looked at electronic health records of 45,000, over 45,000 patients, almost 50,000 patients. And we saw that based on their current drug profiles and the population prevalence of these variants, that about 10% of our population was deemed to be at high genetic risk. About 10 to 40%, about 15% is at medium genetic risk. So 10 to 40% likelihood of having to change a medication or change the dose of the medication. 30% is at low genetic risk, and 50% have no current genetic risk. And this is for reactive recommendations. So in terms of preemptive recommendations, I also say it would be great to have everyone have pharmacogenetic testing at birth, because then we have many more years to utilize this information in our prescribing. And at one point or another in our lives, we are prescribed drugs that can be informed by the current pharmacogenetic variants that we're studying. Next slide. So now let's talk about pharmacogenomics for the underserved. So it's very important as we move forward with the cutting edge of medicine that we do not leave people behind. And often when we incorporate new technologies, we increase the digital and technology divide. So let's take a look at some of the data here. Next slide. So as I mentioned, genomics is failing on diversity. So on the left-hand pie chart, you see in 2009, we had about 1.7 million samples in 373 genetic studies, and 96% of those were of European ancestry. Fast forward to 2016, and we have many more studies, 2,511 studies, 35 million samples, so many more samples, and yet we haven't increased the diversity as much as we could have. And this is something that we're working on at Stanford. I'm submitting a grant for this now. As we mentioned, those of Asian and non-European ancestry are very underrepresented in genomics. And that gives us less information on pharmacogenomics as well. So this is important going forward to have more diverse populations participate in the research so we can do better precision prescribing for all of our patients. Next slide. This is a slide on telehealth use by race ethnicity, which is not exactly the pharmacogenomics, but this may give us a clue as to where we might find disparities in pharmacogenomics. And we are writing a grant on pharmacogenomics specifically to partner with our federally qualified healthcare centers so that we can bring pharmacogenetics technology to underserved populations. So you can see here that telehealth use in general, about 50% have no use of telehealth. And this is overrepresented in Asian and Hispanic populations who are more likely to not use telehealth. Next slide. And when we consider new technological innovations, we have to remember that some people, some groups are using smartphones only. And for instance, the pharmacogenomic software that we use is web-based and is not available through phones. So as we think about new pharmacogenomics technologies, we should think about ones that can be used by populations who are primarily smartphone users. And you can see there are vast race ethnic differences in terms of the number of portion of households with broadband internet. So 65% of Hispanic households versus 71% of Black households versus 80% of white households have broadband internet. Next slide. So not enough is known about pharmacogenomic testing in minority groups to assess whether they are more or less likely to use pharmacogenetic testing. Though we at Stanford are committed to bringing pharmacogenomic testing equally to all race ethnic minority groups and those with varying levels of socioeconomic status, um, so that we can improve health of all of our populations equally. Next slide. And it's important for us to remember that equality is not the same as equity. So I show this cartoon in my population health classes to the first year medical students. And equality means that you're giving everyone an equal amount. So let's say pharmacogenetic testing costs $100 for everybody. That would be equality. But equity is giving more to groups that need more. So perhaps for some groups that are underserved, we're actually making pharmacogenetic testing free or low cost and charging $100 to the people who can afford to pay. So this would ensure more equitable distribution of these new technologies, including pharmacogenetic testing. And our goal is to reduce health disparities, which we've identified in many different diseases, including diabetes, cardiovascular disease, hypertension. And it is my hope that pharmacogenomics can bring us closer to reducing health disparities and bringing health equity to everyone. Next slide. So we have done case reports on interpreting these variants in current pharmacogenetic testing. And this is important for consumers because there's many companies that offer direct-to-consumer pharmacogenetic testing. And we found through a patient who came to us with outside pharmacogenetic testing, compared to the pharmacogenetic testing that was done in our vetted Stanford lab, that there was differences in variant interpretation where the outside lab called the variant as intermediate metabolizer when she was actually a normal metabolizer for one of the very large enzyme groups, which created sort of undue anxiety and frustration. So it's very important as we move forward to use guidelines that are vetted by scientists from around the world, like the Clinical Pharmacology Implementation Consortium, as opposed to relying on individual companies to do their own variant interpretation. So I encourage you to look at this if you are to undergo pharmacogenetic testing yourself, because it can be a Tower of Babel, and it's important to have a good interpreter for this information. Next slide. So where do we go with pharmacogenomics 2.0? So as I mentioned, pharmacogenetic testing can provide information on the medications you currently take and potential medications you may need to take in the future. So that's preemptive recommendations. So this can ensure you take the right medications at the right dose for you. And this is just some information on pharmacogenetic testing at Stanford Healthcare. So this is just a saliva test, similar to a COVID test many of you have maybe taken, which you mail in. And then you have a consultation with a pharmacogenetics expert who at this time is me or Dr. Russ Altman. And so there's a phone number to contact, and you can also look us up on the internet if you just put in Stanford pharmacogenomics and personalized wellness. You'll find this information on pharmacogenetic testing.
Wonderful. If Dr. Palaniappan was here, I would thank her so much for such an informative talk, but I'll have to pass the thanks along after. Now I am really pleased to present one of our guests and panelists, Dr. Manoli Pereira. She is an associate professor in the Department of Medicine in the Center for Pharmacogenomics at the Feinberg School of Medicine at Northwestern. So Dr. Perera earned dual doctoral degrees and trained as a fellow in clinical pharmacology and pharmacogenomics locally there at the University of Chicago, where she is now. During her 2-year clinical fellowship, she studied novel variants related to pharmacokinetic differences in the CYP3A4 gene in African-American patients. She has been funded by the NHLBI and the American Heart Association to investigate novel genetic variants associated with warfarin dose response. This work led to the discovery of a genetic variant that was highly predictive of warfarin-associated bleeding in African-American patients. She expanded this initial focus from warfarin to general drug metabolism and its role in pharmacogenomics through grant funding from the National Institute of Minority Health and Health Disparities to investigate genetic variation in drug metabolizing enzymes in African-American patients. She received the 2016 Leon Goldberg Young Investigator Award from the American Society of Clinical Pharmacology and Therapeutics for her ongoing scientific work in African-American pharmacogenomics. She is currently the PI of one of the other centers with the same funding that was provided to Sphere, and their project is called ACCOUNT, which stands for African-American Pharmacogenomic Cardiovascular Consortium. So Dr. Pereira, welcome to our Stanford Zoom room. We are so pleased to have you. Thank you for waiting, and take it away.
Okay, sorry. Thank you. Thank you for the invitation to speak, and hopefully I'll tell you a little bit about what we've already done and what we're currently doing. And sorry. Okay. So, conflicts, I have none except for my funding, which I have listed here. And I think Dr. Latha had really well described the lack of diversity in genomic medicine. And this is just another review showing how most of our genome-wide association studies and this is not just pharmacogenomics, but all genomics, is really skewed towards European ancestry populations. And so the questions of the seminar, can we use the data we currently have to translate across all populations? And I can give you a couple of examples within our own center and labs about how we do that. And I also like to talk about, people sometimes confuse susceptibility or disease genomics with pharmacogenomics. And because there is a real large amounts of genomic data now available. And we feel like, why can't we reuse that for pharmacogenomics? But pharmacogenomics is a bit more difficult in the sense that in disease genomics, you have people with and without a disease, and you look at their genomes to see if they're more susceptible to a disease. But in pharmacogenomics, everyone has the disease and they're taking a medication, and you have to be able to then determine if they respond to that medication or if they have an adverse event to that medication. And so the level of data collection is really much more intense, and therefore it really is even smaller, a smaller pot of data that we can use for work such as this. And when we talk about the genome and why should we have diverse genomes, in this review article, the same one that showed the figure before, they talked about how there's large meta-analyses now across a trans-ethnic meta-analysis. So shouldn't this solve the problem of diversity? And it really doesn't, because many times these large meta-analyses do associations across ethnicities, but they can't tell you population-specific ethnicities. So in many of these studies, we never really find the causative variant as shown up here. We find these other variants that are close by. But if they're all linked to the causal variant in all the populations, then we've done a great job and it's transethnic. But that's usually not the case. And many times there's different causal variants in different groups, or there's incomplete linkage between the variants that are close by. So that means that when we do these large meta-analyses, the group that has the largest contribution to those analyses usually are the ones that we find associations that are most robust. And by not having dedicated studies in minority populations, we're actually losing out on information. And I use this example that many clinicians will know about, which is PCSK9, which, as you know now, is a class of medications used to treat hypercholesterolemia. It was discovered in a genetic study, and it's because people with variants in PCSK9 gene had very, very low LDL cholesterols. But what you may not know is that the variant, that coding variant they found was at highest frequency in African-American populations. So had they not included African-American populations, actually we would have never discovered this gene, and we wouldn't have this class of medication. I study African ancestry populations, and a lot of this stems from the very unique contributions that the African ancestry genome can give us. So for those of you who don't know, we as a species arose in Africa, and this little schematic here shows that, and then we migrated throughout the world. But that also means that people of African ancestry are the oldest population on Earth. And as such, they have the most genetic diversity. So any diversity we see in Europeans or Asians is actually just a subset of what we find in an African genome. African Americans are admixed. They're mixed between Europeans and Africans, with the majority of their genome coming from their African ancestor, about 80%, with some of it coming from their European ancestor. We know about health disparities in diseases, but if this is a pharmacogenomic talk, I'd be remiss not to talk about drug metabolizing enzymes. So CYP3A5 is one of those liver enzymes that metabolize drugs, and the CYP3A enzymes metabolize between 40 to 60% of the currently prescribed medications. And what you may not know is that in this gene, there's a splice variant. That means that if you carry the splice variant, you have a non-functional enzyme. A majority of European ancestry individuals carry that splice variant, so they do not have CYP3A5 in their liver, or very, very low amounts. Most people of African ancestry do not carry the splice variant. So they actually have this active working enzyme. And so, of course, this has implications for pharmacogenomics, but I think we should think of this more broadly when we think about clinical trials and the makeup of the population of clinical trials. These are trials that tell us what dose of drug we should be giving, the effective dose, the toxic doses, the pharmacokinetics of the drug. If we do all of those studies in predominantly European ancestry individuals, well, we're missing out on things such as the CYP3A5 enzyme, which may differ drastically between African ancestry populations and admixed populations, African Americans being one, but Latinos being another. I started my work in African American pharmacogenomics with warfarin pharmacogenomics. So warfarin, as you guys may know, is an anticoagulant with a very broad dosing. So some people needing very small doses, some people needing very large doses. And it has been studied for many decades now, with 3 major genes contributing to dose requirements, and they're listed here. And all the efforts in warfarin have shown that if you use the variants in these genes, as well as demographic and clinical factors like age and weight, smoking, other medications you're on, you could explain 65% of the variability in dose. So that's really, it's huge when you think about it. But if you use the exact same variables in an African American population, you only explain about 25% of the dose. And so this led to a consortium effort. I was part of a large group, including Russ Altman was also a driver of this study, in which we looked specifically within African Americans for genetic variation that affected warfarin dose. And these were the findings of that paper. This is a Manhattan plot that shows every genetic variant or SNP that we tested across the genome, shown by chromosome. And this green area here shows our significant finding in chromosome 10. This is the same chromosome that holds CYP2C9, the enzyme, the liver enzyme that metabolizes warfarin. Except this variant is not in CYP2C9. It's close to that locus, but it's actually quite far from the gene, and it's not even within a gene, it's intergenic. But it was highly predictive in African Americans, such that, and it was very common. It had a minor allele frequency of 25%. So this means practically for African American populations that 47% of African Americans carry at least one copy of this SNP. This discovery led to changes in the CPIC guidelines. And so in the previous presentation, we talked about CPIC guidelines that help us guide therapy for drugs with genomic information. And you can see here, there's a bifurcation. If you're non-African, you go through this pipeline. And if you're African ancestry, you go through this pipeline with many coding variants in CYP2C9, as well as the variant we discovered in this genome-wide study. One of the challenges that came up with this study is that many of our reviewers asked us, what does the SNP do? It's in the middle of nowhere. It's not in a gene. And to answer that question, because this was an African ancestry specific finding, you would need data that had genomic data and maybe some sort of gene expression data in liver of African Americans. And at the time we published this, no such data existed. All the data of paired multiohmic data, as we now refer to it, was always in European ancestry individuals. So we could never answer that question. A study that came out of this work in warfarin was looking at bleeding risk. And so bleeding risk is a rare but can be very serious complication of anticoagulation. And this is true for warfarin as well as the new agents, direct anti-10A agents that are now out. African Americans suffer from bleeding at a higher rate than other populations. And there are already known clinical factors that affect that: chronic kidney disease, age, sex, cancer. But where does genetics play a role? And in all the studies previously, they had looked at the variants that affect warfarin dose, and they had thought the CYP2C9*3 variant may be a really good candidate for bleeding risk in warfarin dosing and in anticoagulant dosing. Except African Americans actually don't carry this variant. It's at very low frequencies in their population. So we decided to run this with this genetic association, but again, this is a rare event, and I wanted to look at genetic variants that would affect warfarin when other environmental variants didn't affect it, or were less likely to affect it. For those of you who dose warfarin, you know that the INR is the way we measure how anticoagulated a patient is, and usually you're trying to be between 2 and 3. And so this graph kind of shows you the drop in this case, stroke risk with the increase in bleeding risk after an INR of 4. And so if you have a high INR, honestly, this is not something we want to predict with genomics, because a physician can get an INR, can see that the INR is high, can stop dosing, can reverse the drug. They have lots of things that would tell them this person is at high risk of bleeding. But what about for people who bleed within the therapeutic range or just outside of it? This is less predictable. And this is where genomics can really benefit patients. So we decided to look at bleeds that occurred at an INR less than 4, that were hospitalized bleeds. And we used 4 also because in many clinical trials, an INR greater than 4 was considered an adverse event for warfarin. We had very few cases in both our discovery and replication, but the majority of bleeds we found in African Americans actually happened at an INR less than 4. On top of that, there are bleeding schemas that are currently available. And this is the postdoc that led this entire work. So she looked at every one of the bleeding schemas that use clinical variables to tell you how likely somebody is to bleed when they're anticoagulated. So you get points for things like stroke or elderly or drug abuse. And the greater amount of points you have, the greater your risk of bleeding. And when we had a discussion about this genetic study, I said that if we find something that is less predictable than these factors put together, then it's really of no clinical use, because we could measure all of these out of the EHR and figure out someone's risk. So we need to do better in genomics than just what we can pull out of the EHR. And these are the findings from this study. We were able to find a genetic variant in chromosome 6 that we were able to replicate. But what I really like you to focus on is this ROC analysis. So this tells us how predictable we are using either a bleeding schema shown in red or the bleeding schema plus the genetic variant. And as you can see, we increased our predictability of those people who would have hospitalized bleeds or major bleeds using our SNP. Now, this is not a really impressive ROC curve, but we're certainly doing better than we were with just using clinical data. And this is the gene we found on chromosome 6. It's called EPHA7. And I think the important takeaway here is first, the population skew of the allele frequency. This is the allele frequency in whites, Asians, people from Africa, Africans, and African Americans. And as you can see, the variant we found is only found in African ancestry individuals. So the only way to find this association would have been to look in African Americans. Had we done this in a European population, we would never have identified this gene. Now, this is, again, a common variant. You can see here it's 7% in African Americans. So there are lots of African Americans walking around with this variant. They do not have a bleeding disorder. We hypothesize that perhaps this is a gene drug interaction in which when people are anticoagulated, they have blocked a lot of their natural pathways to prevent bleeding. And now these very minor pathways become important in protecting people from major bleeds. And that's how we would be able to uncover this in a genomic study. So it's a really interesting finding. It's an opportunity and one that we could have only done by studying African Americans. Our lab really works on thinking about function. And as I said, we had no liver data, which is the organ that metabolizes most drugs that we work in. So for in pharmacogenomics, this is incredibly important. So we decided to build our own database where we looked at hepatocytes, collected multiohmic data on all of these African hepatocytes collected from African American livers. We did drug induction studies to change the transcriptome to see what happened, what we could find out, and also pharmacokinetic studies. And I'll just give you a couple of little snippets that, there's several publications that came out of this work. You can see that there are many ways to combine this data. So multi-omic data is actually really the future for precision medicine. So you could look at gene expression. EQTLs are SNPs that affect gene expression. That's the significantly affect gene expression. That's all it means. You could look at differential gene expression between different drugs. You could combine all of these into, machine learning models. But I'll just give you some really clinically relevant ones that we found. So one of the things that was very unique with our data set is African ancestry varies in African Americans. And in our livers, it varied anywhere from 48 to 94% African ancestry. So people think of African Americans as monolithic, but they are not. They're highly diverse. And so even within the populations, there's diversity that we should be thinking about. When we looked at the gene expression in the liver and looked to see if it correlated to this component of African ancestry. Out of the pharmdkb genes, we saw that CYP2C19, which is the enzyme that converts clopidogrel to its active metabolite, had lower expression the more African ancestry you had. And this P2Y RY1 gene, which is actually a target for clopidogrel, but has also been associated with heart attack, stroke, and DVT, all of which are health disparity conditions for African Americans. The more African ancestry you had, the more expression you had of that gene. We also, so from that, we decided to build this consortium, and we built it in both Washington, D.C. and Chicago to really accelerate the pace of pharmacogenomics in African Americans. And I'll just give you, again, a quick overview of some of the things we're doing and collecting. And so all of these are still in progress. So we've collected large data sets of African American patients taking warfarin, the DOACs, which are the direct oral anticoagulants, the drugs that are replacing warfarin, and clopidogrel, because these are the drugs that are on the forefront of having genomic information that's informative to patients. We collected lots of different biological samples. We tied into other major databases and with potential to use new technologies with these samples. We collected drug response phenotypes from all of our patients, as well as adverse events phenotypes. So this is an ongoing project to really see if there's new discoveries to be made, specifically in African Americans. And I want to say all of these drugs have already been looked at in European populations. We also had a translational piece to the work we did, and this was led by my colleague at University of Chicago, Peter O'Donnell, where he preemptively genotyped African-American patients with preemptive, these were all SNPs that were found in CPIC with CPIC guideline assistance, and then delivered them back to the patient and provider. And just we've already recruited 500 patients into this project, but just a quick, reminder, can we translate pharmacogenomics into African Americans? In our initial results from this study of giving back these preemptive testing results, we showed that there were less alerts given to patients of African ancestry as opposed to others. And this does not mean that they don't carry variants that affect pharmacogenomic that they don't have pharmacogenomic variants. It means that the databases that we're pulling them from may not adequately house the data we need to translate yet. And so they're getting less alerts. And this is just our website for anyone interested in what Account is doing. And I wanted to end there. I'm hoping I'm on time. This is my lab group who do absolutely all the work I presented and all of my collaborators. And this is our last Account meeting. This was the consortium we built, and it has become a real guiding force in everything we do. And as you can see, we do have a collaboration here with PharmDkb in Stanford. So it was really a very fruitful collaboration. Thank you.
Thank you so much, Dr. Pereira. Wonderful. So I'm going to now introduce Dr. Megan Mahoney. She is a clinical professor in the Department of Medicine here at Stanford. She's also our chief of staff at Stanford Healthcare. She has a passion for teams and technology in healthcare and has led team-based care redesign efforts and the Precision Health Initiative that we call human-wide. Before joining Stanford, she was a faculty member at the University of California, San Francisco, just up the road for 10 years, where she served in several leadership positions as well in clinical operations, medical education, as well as research. Dr. Mahoney endeavors to provide patient-centered and compassionate services that enable patients to reach their health and wellness goals. Her academic focus is to develop innovative and transformative approaches to proactive and personalized team-based primary care that empowers patients, healthcare providers, and communities in the US and globally. And Dr. Mahoney, I'm so thankful that you're here and can't wait to hear your presentation.
So it's lovely to be able to have this opportunity to discuss with you all our experience with implementing a pharmacogenomics program in primary care at Stanford called Human-Wide. And it was great to hear Dr. Palaniappan refer to that, present some of the outcomes from a pharmacogenomics side. What I'll be doing today is talking about the implementation science involved in implementing a program in a clinical setting, and how this primary care team was able to leverage not only genetic testing, pharmacogenomic testing in a clinical practice in a routine basis, but also the integration of home wearable devices and social determinants of health in order to provide precision health to our patients. So it was the confluence of all of these data streams that we were hoping to provide to the patient to be able to craft a very effective treatment plan for that individual patient that was in front of us. And so on the next slide, and thank you, Minoli, I appreciate this. We all know that there are many lessons that we have learned from the COVID-19 pandemic. One important lesson being the importance of integrating social determinants of health. And one of the ways in which primary care can be so powerful is by addressing social determinants of health throughout the life course. And so as I start thinking about COVID and the related increased mortality that we experienced last year, a lot of that is because of the disease related to COVID itself, but a lot of it has to do with deferred preventative care and deferred chronic disease management and people not coming in. And so I think now more than ever, we can appreciate the important role that primary care can play and the ways in which integrating social determinants of health into primary care in a precise and individualized and personalized way can be incredibly powerful. So on the next slide, you'll see that there's, currently there's a mismatch between our delivery system and the drivers of health, as shown here. There's a maldistribution of resources, with the care being provided at the top of the inverted pyramid on medical campuses, of course, our fee-for-service paradigm currently supports that, and that really does characterize our healthcare system. but it's simply not sustainable. Costs have continued to skyrocket without proportional improvements in population health, and we cannot bend the cost curve without devoting more attention to prevention, chronic disease management, and wellness strategies. So on the next slide, this is the best of primary care, taking a life course approach to precision health. We're able to leverage the numerous opportunities throughout someone's life to assess their at birth, as Dr. Palaniappan alluded to, it would be ideal to get a pharmacogenomics assessment at birth so that their entire life can, all those years of benefit from that data, and then also the accumulation and the improvement of the database and what we know will improve over time. There's also an opportunity to integrate medical imaging, family history, the physical conditions that someone experiences, and then also all of the biomarker data and the data that we get from digital health devices, all of that being integrated and taken advantage of throughout the entire life to prevent disease, to act very early on when there is an onset of disease, and to then craft a treatment plan that's very specific to the person in front of us. And like I said, this is the best of primary care when it's longitudinal, when we have a life course approach. And hopefully, as we are starting to very clearly see that there's better quality outcomes, value outcomes, cost reduction associated with the involvement of primary care. If primary care providers are given the tools to become even more effective and given a team to work with, they can provide this high touch and high tech care that we know would be the benefit of our patients and also probably the entire healthcare system. We'd also need to include effectively the determinants of health, social determinants of health, environmental determinants of health. And that's what we attempted to do with Human-Wide in 2018. So on the next slide, you'll see that this is a description of the Human-Wide pilot that occurred in 2018, a 12-month pilot in a primary care clinic at Stanford. The goal was to provide personalized care at all points of the care continuum: wellness, prevention, treatment, chronic disease management, and complex case management. And on the next slide, you'll see all of the different components. So there was health coaching with a 1-hour wellness assessment, and primary care providers and were involved in health coaching on an ongoing basis. There was integration of digital health data that was acted on. There was also pharmacogenomics testing using the saliva-based screening for drug-gene interactions, and then genetic screening to assess risk for the CDC Tier 1 markers of hereditary breast and ovarian cancer, Lynch syndrome, and familial hypercholesterolemia. And then these, all of these components were integrated, and the care was crafted specifically for the individuals in front of us. A lot of workflows were sorted out. We had genetics counselors, we had Russ Altman involved, and a very multidisciplinary team. So I want to leave time for questions. So what I'll probably do is go through the rest of the slides fairly quickly, but I know that they'll be distributed. So this is again another description of all of the specific components. On the next slide, we'll see how we were able to leverage the data in order to more effectively risk stratify patient populations, and then avail the most appropriate team and services based on the information that we were putting together for the patient. On the next slide, this is just the specifics about the study. Yeah, sorry if you keep going forward. Yeah, on the next slide, we'll skip over this one. this is has to do with just the recruitment. So we intentionally recruited a diverse population along the lines of health complexity, race, ethnicity, age. And on the next slide, you can also see that we were able to look at implementation outcomes, penetration, reach, acceptability, feasibility, sustainability, and this was achieved via chart review and semi-structured qualitative interviews. And then on the next slide, you can see the patient characteristics reflected the patient demographics of the clinic that we implemented this pilot in. The next slide. Implementation outcomes, you can see that in the pharmacogenomics column that most people participated in the pharmacogenomics testing, and that in general from the patient's perspective and also from the provider's perspective, they saw the clinical value of integrating pharmacogenomics data into crafting the treatment plan, or even titrating medications based on the information. And most people who were on chronic disease management medications had an effect. They had an intervention that was that they experienced because of the data. So it ended up being very helpful. The only negative aspect of acceptability was just not having, among the primary care providers, not having the expertise to be able to interpret and analyze the data. And then we also, and this was discussed earlier, there were some limitations in integrating the data into our electronic health record. And since, you know, primary care providers frequently rely on the electronic health record, that presented itself as a limitation. And so with that, if we go and advance the slides, I do have some very specific recommendations, and actually Dr. Goldman Rosas participated in this as well, specifically about pharmacogenomics testing in a diverse population. There was a push recommendation based on interviews and across the care teams and patients that there was an appreciation that we do need to increase the representation of all races and ethnicities in the pharmacogenomic database, and to also just have open and build trusting relationships as we interact with our patients and discuss genetic and pharmacogenomic testing. And then finally, of course, it will be important for us to address the coverage of these tests going forward. It will not be feasible without having insurance cover it in the near future. So with that, I think I will just end. There's just some more summary slides here, but I did want to allow there to be some time for questions. Thank you.
Thank you so much, Dr. Mahoney, and for keeping us on time. I know it's always difficult to be the last person as the time accumulates, and we appreciate your accommodations. So I'm hoping you guys can stay on just a little bit longer. We have 2 questions that have been submitted. So the first question is regarding gene expressions in the liver. How are various blueprint provisions utilized to identify specific variants? And Dr. Perera, I'm wondering if you have an answer for that.
I'm not sure I understand the question. I'm not sure I know what blueprint.
Oh, okay, I thought maybe it was just me. So I'm very glad to hear that you don't either. For Sherilyn Fox-Reeves, when you submitted that question, if you could explain the blueprint provisions, we would be happy to answer. We have another question submitted in the chat, and I think this is a very interesting one. And it says it's for you, Dr. Perera, as well, and I think both of you could really answer this. Does genetic variability differ in biracial populations? Interesting topic.
I think this is a really interesting piece, and I can't say that I know the answers. What we will say is that, ancestry within African Americans again varies, but what do we consider truly biracial? Biracial is a social label, and so I think it does increase the diversity and the makeup, especially of the ancestral makeup of people who considers themselves biracial. And we don't have a lot of data, though I think we have opportunities because there are other countries outside of the United States that have large, what we would consider biracial populations, things like Brazil, where we have lots of admixed people of different ancestries. And so those are the places I think we need to look to answer that question.
Thank you. Dr. Mahoney, do you want to comment on that? What it's like for patients in primary care that you might talk with?
I think that there is an incredible promise with precision health and moving away from biological race entirely in the use of biological race in healthcare. Precision health will give us the additional physiologic markers, biomarkers, the additional different information that we need so that we can move away from crude proxies such as race.
Great, thank you. I think that might be particularly helpful for biracial patients who don't see themselves fitting into any one category that we have offered in healthcare. So I want to end with a question. All of you brought up this issue of representation in the genomic databases that we are relying on to develop these new strategies. Can you talk about what we need to do to get there? And we'll kind of end with that last question. So, what's on the horizon in terms of research and practice for both of you? Dr. Pereira, we can start with you.
Thank you. So I think one of the bright spots, especially for pharmacogenomics, hopefully will be initiatives such as the All of Us effort that will bring a lot more genomic diversity, certainly US genomic diversity. And I've talked about admixed populations of African Americans, but Latinx populations are very admixed and are even less represented in genomic research. So really what we need is data, and really good data with deep clinical matching clinical data. That's what's missing.
Great. And Dr. Mahoney, how about for you? What do you feel like is on the horizon to get us to this next step?
Yeah, sure. Thank you for the question. I would just say from a clinician, standpoint that when we were implementing the human-wide study, it wasn't clear that the recommendations that we were making based on the pharmacogenomics findings actually led to a treatment outcome difference. And so the effectiveness of a pharmacogenomics program, I think, would be really helpful, in addition to the cost effectiveness, so that we can convince insurance to cover it. And then in addition, we would also want to look deeper into the acceptability and feasibility of a program among the primary care providers.
Great. So some further implementation work, building out what we started with. Wonderful. Well, I'm going to pass it off to Dr. David to close us out and to give us a heads up about the last seminar in our series. But before I do that, I want to thank Dr. Palaniappan in her absence, and hopefully she can see this video, and then extend a really warm thanks to you, Dr. Perera, for joining us, and to you, Dr. Mahoney, for being here as well. I really appreciated the perspectives that both of you brought. Okay, Dr. David.
Again, thank you very much to both of you. Really is bench to bedside and cell to society conversation, and I really appreciate you taking the time. So we will be convening again for our fourth and final seminar in the Precision Health Equity and Primary Care series next Thursday. We will be focusing on polygenic risk scores in primary care screening. And the speakers will be Dr. John White, John Woody from University of California, San Francisco, Hannah Wand, and Jennifer Kim from Stanford. So please join us next week, and make sure that you don't forget to get your CME credit and complete the evaluations. I want to again thank our guest today and my co-host, Dr. Goldman Rosas, for a really great seminar once again.
Thank you all.